Mark Latina. I'm a physician, ophthalmologist, and glaucoma specialist, associate clinical professor of ophthalmology at Tufts University School of Medicine. I'm in private practice in the Boston area, and I'm the inventor of selective laser trabeculoplasty. So the idea of how I actually developed SLT was really a simple question was, do you need to photocoagulate the trabecular meshwork in order to achieve a biological response of lowering intraocular pressure? And secondly, is there a way to selectively target the trabecular meshwork cells while preserving the trabecular meshwork structure in order to result in a lowering of intraocular pressure? My feeling was that with the current use at that time, the current use of argon laser trabeculoplasty, that we were photocoagulating and destroying a significant amount of the meshwork, and we knew there was scarring of the trabecular meshwork. But part of the response to the laser was actually to create a biological response and resulting in a reduction of intraocular pressure. My idea was that this was like taking a shotgun and in order to kill a fly, so resulting in significant collateral damage to the surrounding trabecular structures. So could we do this in a way that would preserve the trabecular structures and again achieve IOP reduction? So we went out to figure out how to selectively target the trabecular meshwork cells without coagulating the structure in order to again result in IOP lowering. We looked at a variety of laser systems, laser pulse durations, laser energies, laser wavelengths. The bottom line was that using a 532 nanometer frequency double neodymium YAG laser, which is a short pulse laser, that we could achieve selective targeting of the trabecular meshwork cells. So this was sort of the first step. The second step was, of course, to try this out in monkeys, in animal models, and we did that and showed that we could selectively target these cells, both actually in vitro and in vivo. And then the third step was, of course, to try this in humans and perform clinical trials. The results of the initial studies were actually done in Mexico prior to the FDA clinical trials that we did in the United States, and we showed that we were able to achieve significant IOP lowering in these preclinical trials using this technology. We then went into FDA clinical trials in the United States, multi-center clinical trial. And at that time, patients were on maximum tolerated medical therapy, and we were able to show that there was a significant IOP reduction in the treated eye compared to the untreated eye. So my experience with SLT has, of course, changed over the years. Initially, as we indicated in the FDA clinical trials, SLT was used following on patients who were on maximum tolerated medical therapy. The reason for this was because argon laser trabeculoplasty was used as a step procedure, and laser was sort of a second stage procedure after patients were on medication, and we weren't, as ophthalmologists, really using laser trabeculoplasty as primary therapy. What was interesting was that the glaucoma laser trial was also being performed at that time, and that trial did indicate that even using argon laser trabeculoplasty as primary therapy, that it would be potentially as effective as medications. The problem with argon laser trabeculoplasty was that physicians did not really adopt that technology as primary therapy because of the side effects and the sort of destructive nature of the procedure. So it was never really again adopted in clinical practice. So the FDA was not familiar with this, and so we had to perform the studies using patients on maximum tolerated medical therapy. In Europe and in Israel, Choka Melamed actually did one of the first studies looking at SLT as primary therapy, and the result of that study was extremely encouraging. and showed that there was, when used as primary therapy, that patients achieved a 30% or greater reduction of intraocular pressure. So this was sort of a paradigm shift now in our thinking of using laser as first-line therapy. And so over several years, we began to use laser earlier and earlier. And we performed a large multi-center clinical trial in the United States called the SLT MIGS study. That study showed, it was a comparison of SLT as primary therapy, treating 360 degrees of the trabecular meshwork, compared to prostaglandin as primary therapy. And the result of that study was that the SLT was equivalent to medications, in this case prostaglandins, as the primary therapy, with equivalent reductions of intraocular pressure. And actually the SLT group showed less medication step requirements, in other words, the need for additional medications to lower the intraocular pressure compared to patients who are on medications. So that really led the physicians to, again, broaden their use of SLT as primary therapy, and that's what we are doing now. We actually recommend SLT. I recommend SLT to my patients who are coming in who are not on medications and are being diagnosed with glaucoma as their first-line therapy. SLT can also be used, of course, in patients who are on medication, and the goal in my practice is actually to reduce the number of medications patients are on. So we like to actually take patients off medications, allow their pressures to rise if necessary, and then treat them with the laser and see how they respond. If they respond well, of course, we can again begin to replace or remove medications for these patients, which overall helps their overall compliance and improvement of glaucoma control. So SLT is primary therapy. So again, multiple studies, most importantly the SLT MIGS study, indicated that SLT was highly effective as primary therapy. What we do know is that when SLT is used after medications, that the efficacy is somewhat lower. And the reason for that is, of course, there's only so much that the trabecular meshwork and the outflow pathways can achieve. So if you're already utilizing one portion of the outflow pathway and again adding SLT as an additional therapy, then just like adding a second medication, the percent IOP lowering is going to be reduced. We actually did a study looking at SLT in patients who were only on a prostaglandin versus SLT who were only on aqueous suppressants. We then treated them with SLT laser and looked at their percent IOP reduction, or number of patients who achieved a given percent IOP reduction. What we found is if these patients who were already on a prostaglandin and then were treated with SLT, that the percent success rate was about 50%. In contrast, patients who were on aqueous suppressants and that were treated with SLT, that the success rate was virtually 100%. This suggested to me that the SLT and the prostaglandins were potentially utilizing the same outflow pathway. So if you are already utilizing that pathway, such as prostaglandins, which improve the uveoscleral and potentially trabecular pathway, and SLT, which is a trabecular outflow pathway as well, that you're going to get reduced success rate with the laser. So for this reason, again, the more medications that the patient's on, the lower the probability of quote-unquote success, that is achieving significant IOP lowering. So again, we like to see the patients not on medications or as few medications as possible. And for me, I like to see the patients actually taken off the prostaglandins, because I think the prostaglandins may actually interfere with the efficacy of the laser, simply because it's utilizing a similar pathway to the laser in lowering IOP. Since the advent of MIGS, of course, there's been a lot of attention drawn to using the MIGS procedures. I think the SLT actually probably plays a more important role now than ever. because of, I think, one important point. One, we're still using SLT we still like to use SLT again as primary therapy. Secondly, SLT is non-destructive to the trabecular meshwork compared to argon laser trabeculoplasty or even MLT, micropulse diode laser photocoagulation of the trabecular meshwork, because those procedures actually cause scarring of the trabecular meshwork. And what we need in the MIGS procedures, at least those procedures which are utilizing the Schlemm's canal, is an intact Schlemm's canal. We do not want to see scarring of the Schlemm's canal. So in my opinion at this point, actually argon laser trabeculoplasty is contraindicated if you have any indication or desire to perform MIGS procedures in the future. It's more recent that SLT may be used as a diagnostic tool to help us in determining whether the success of these MIGS procedure, and I think that's a quite intriguing question actually. What we do know is that, of course, that a majority of resistance probably lies in the juxtacanalicular region of the trabecular meshwork. What we also know is that in patients with more severe glaucoma, that there can be herniations of the trabecular meshwork and Schlemm's inner wall of Schlemm's canal into collector channels, causing blockage of blockage of the collector channels. What we want, of course, in these procedures is access to the collector channels so that there's improved outflow, as well as improvement of bulk flow across the trabecular meshwork. So this suggests that if SLT is actually successful, in other words, patients who've had SLT and achieve a reasonable IOP lowering, that indicates that at least we would know that the collector channels are open and clear, and this may actually help, maybe potentially be a predictive for the success of other MIGS procedures. So I do think the data is not, we don't have a lot of data on this at this point, but it's highly suggestive that SLT could be potentially predictive for this purpose.